So I start with the next talk that is about transition, so a little bit the older boys or young men. I carry on to say boys and then they get really crossed. So I always start because when we talk about, the topic that I've been given was transition. And I would like your help to understand what is transition. Because I think that is really unclear. And one of the points is whether transition is a clinical definition or is a system definition. So there is transition means that is the transition of the condition that change over time and can be interpreted quite often, and it's clearly when we talk about clinical trials and sometimes also in terms of care, the transition seems to be associated with the loss of ability to walk. So is this change from the ability to walk independently to becoming non-ambulatory. And this is the problem that if we consider this as a definition in terms of age, is really variable and change over time. So 10 years ago, probably this time was around the age of 10 to 12, and now is more around the age of 12 to 16. So in terms of age, it changed quite significantly. Or you can say the transition is regarding becoming an adult, so becoming 18. And this is another implication, because regardless whether a boy has lost ability to walk 3 years ago, or 3 years, or 4 years before, or just lost ability to walk, or is still ambulant, because we now have some of the boys, the young man with Duchenne, who are still ambulant or able to do a few steps at the age of 18. So regardless their function, the big change is they become an adult and therefore they change the service. So you move from a pediatric clinic to an adult clinic, and this is another huge problem in the UK. So that is when I struggle a little bit, because I don't know exactly what I need to talk about in the next 40 minutes. But my point is I will focus in a way on the care. And focus on the patient and not on the service. But I think that we cannot deny the fact that in the UK is a little bit tricky. We have a huge service in pediatric for patients with neuromuscular. There is the North Star consortium that has been established for several years, and there is some sort of agreement in terms of care. Newcastle is the only neuromuscular center in the UK that cover from pediatric to adulthood. So the same T is seen the patient from age 0 to age 99, which is a huge advantage, because it means that and the patient doesn't actually have to change any team, everything remains consistent. Everyone else moves from a pediatric neuromuscular team, ideally to an adult neuromuscular team, and quite often to neurology. And when you move to neurology, there isn't so much the culture of neuromuscular diseases in neurology. This is changing. So Professor Ross Quillivan, working in London, is actually working really, really hard to establish the North Star Adult Network. So to put together the neurologists with an interest in neuromuscular diseases in order to develop exactly the same culture, the same guidelines. And Dr. Quillivan is also working in developing the standard of care for adults with Duchenne muscular dystrophy. So there is a lot of work there. And there is also more and more physiotherapists and neurologists that are expressing interest, because to be completely honest with you, took a while to realize that, but probably until 15 years ago, there were not so many adults going. So quite often the young man stay in pediatric for a little bit longer, 2022, and then they stay at home and they have more consultation at home. When now we have a growing population on adults with Duchenne that need to be addressed. And we are working on that, but we are definitely behind to what we should say. The other problem is, again, I'm not usually promise spending time criticizing the NHS, because I don't think I'm a good supporter of the NHS for what it is, but has some limitation. And one of the problems is that, and I will talk about that in terms of service that can be provided, are definitely more intense in pediatric. And the extreme case is physiotherapy. You can have access to physiotherapy in pediatrics, and when you become an adult, suddenly you do not need physiotherapy, which for Duchenne is exactly the opposite. It's probably when you really need. So there is a lot of work that needs to be done on that. But I think that there is a positive thing, as I mentioned for the talk before, there is the updated care recommendation has been published in January this year. In 2016, I can tell you that the standard of care were only for pediatrics. Was very, very, very limited things about adult or older patients. When the updated care recommendations are in 3 parts, and in the 3rd part there is a full section about transition. And is really thinking about, generally, I think the general message of the updated standard of care is we need to be ready to have an adult population with Duchenne. So that is the work that we need to do, and this is the updated standard of care are the preparatory work on that. But it is recognized that the implementation of the care that we gave have created, in a way, a quite vast adult Duchenne population that need to be addressed. I thought that there was another slide earlier, but I have it later. But it's true that we are talking about transition. And transition is still give you the idea that it's something that will cover a restricted period of time. What is next? So the adult is not there yet. But what do the standard of care say about transition? And how they define it is really the young adult with Duchenne. And they identify different areas of intervention that should be focused and should be specific for this group of people at this specific time. And I will spend the next few slides to go one by one. So the first message that the definition for the standard of care is actually the transition is the service related. So it's the transition from adolescence to becoming an adult. So it's not related to the mobility, but is related to age. And the advice is that the transition should not be just happening, that is quite often what happens now, that you are under the pediatric care until the age of 18, and then you move to the adult care. The idea of the standard of care is that a transition should be put in place and start a discussion from when the young man is 13, 14, in order to have a continuation of the care. Ideally, and is what, for example, Ross Quillivan has done in London, is to create a transition clinic. So Newcastle is lucky enough that we can see everyone. But in other places is the transition clinic. So you are under the pediatric team, then you have for 2 to 4 years a care that is taken by pediatric and adult together, and then you move to the adult. And that is the ideal plan. But one of the limitations of the standard of care, that the updated standard of care, that are different compared to the previous in 2010. The one in 2010 were the minimum things that everyone should have guaranteed. The updated standard of care are the ideal things that you should receive, which has advantages and disadvantages. So quite often, the updated standard of care are expert opinions, are the opinion of an expert in the field, but they are not always supported by strong evidences. This has the advantage that, in a way, is a little bit more ambitious compared to the standard of care published in 2010, because tell you if you really want the best care, what should we aim for? And this is one of the examples. We should aim for a transition clinic, so a continuation of the care. But doesn't give me 10 papers that I can take to the trust or to the NHS and say there are proof that if you do it, you definitely have benefit. And therefore, you are asking to change the system, and changing the system is not something that I can say has been published in 2018 and we need to change the system. It's something that we need to work on, which creates a lot of frustration. One important point, I think, at the same time, that we need to recognize is, probably I have it, the next one, is that the transition is a complex time. A lot of things happen. The problem here is that exactly when the person with Duchenne moves from the pediatric to the adult in this transition is exactly when he has the main change in his life. is when he starts struggling walking, is when he might start having some symptoms and feel weak in his arms, is when they might start to need some ventilatory support, is when they might need to go to the hospital more often. And this is very stressful. But at the same time, from the other perspective, for example, for the adult neurologists, they actually get involved in the care of this group of patients in a very complex time when they do not have a large experience. And then it is a discrepancy that need to be addressed. And this is what I was saying, that a lot of things happen and a lot of things need to be addressed at that time. It's a quite tricky time, I think. I always see transition as something that needs to be taken seriously into consideration. When they are really young, we know what to do, they are doing well and you perform well. When they're older, they become very stable. The transition is when there are a lot of changes and you need to be there. But let's look into the specificity of the different suggestions compared to the updated standard of care. The first point, which is not necessarily the most important, but I think that still have a huge importance, is, as I mentioned, is the health care. So the care recommendation just say that they need to think about how to transition to the adult health care. And one thing that they highlight, which is not always simple, is that we need to recognize that they are becoming adult. And therefore, both to the parents and surely the clinician has to realize that. And they has to realize that the question should not be addressed to the parent anymore, but should be asked directly to the patient, which is an adult who has their own opinion and has to make decision on their own care. For Duchenne, I think that is particularly difficult for both sides, for the parents and also for the young man, because it's the time when they become physically more dependent, and it's a time when it's just the end of their adolescence and there are a lot of doubts. And it's so easy to see just that the young man actually asks mom, what shall I answer? And it's very difficult to interrupt this dynamic. And also in busy clinic, I also understand that it's easier for a clinician to ask mom that answer the question in 3 seconds instead of asking the young man, who's for the first time need to be introduced. But that is a work that needs to be done. And then need to be really focused on the changes and on the changes to the age and the different needs per age and the different health need per age. One thing that I want to mention, although we've already talked about that a little bit before, was about the steroid during the transition. As I mentioned, the standard of care highlight actually the recommendation that corticosteroids should be continued in adult with Duchenne, although with the consideration of the balance between side effects and benefit. But the side effects remain there, and some of them become particularly tricky in transition. So the weight is when they lose the mobility, and therefore weight can become a major concern, and then become more difficult to control and manage. The vertebral fracture, they are starting sitting, they've been on corticosteroid for several years, and therefore they have a higher risk. And I would say that the transition is where we see probably the higher number of vertebral fracture and even asymptomatic vertebral fracture. The short stature, the height become a major issue. I mean, is the time when there is a lot of change and appearance count, unfortunately, in this ward. And when they look both for the height and for the delayed puberty, they have so many that come to me and say, everybody treat me like I'm a child. I'm not a child anymore. And this has a huge impact on the psychological aspect. So as much as we say we need to continue corticosteroid, we need also to realize that the side effects profile become quite prominent. And therefore, the idea of finding a balance is essential. And I think it is really talking to them. But is when I found it very difficult also to talk, because you also say, okay, you want to grow, you want to go through puberty. At the same time, if we stop steroid now, is when you start struggling more physically and create a lot of frustration. As I mentioned, the problem is that we are all focused about, quite often about contractures management and stretching, where at the diagnosis, and everybody say, young, you need to stretch the ankle. But the real problem becomes for contracture, so when your joint start to struggle moving, is when you lose muscle strength, and especially when you have spent most of the time, or all of the time, in your wheelchair. And it's not the ankle, but it becomes more a problem with the knees, with the hips, with the wrist. And therefore, in the transition, our thing is the same thing of prevention that we used to suggest. We suggest to start stretching in the ankle at the time of diagnosis, around the age of 4. At that time, the boys do not show any ankle contracture, but you start working with the family and with the child about we need to prevent it. And the same has to happen in transition for the knee, the hip, and the wrist. You need to work prophylactically, even if they do not have any contracture, but you need to work hard on that. You need to think about when they start losing the ability to walk, what can we do to maintain? Sometimes I say, why are we so obsessed about maintaining standing? I don't really mind. Sometimes the idea of walking, if it becomes a non-functional walking, is really frustrating. That they take ages, and a lot of them say, okay, when I am in a wheelchair, I feel better. I don't run the risk to fall. I'm not scared, and I can go as fast as my friends. But the problem is that if they sit all the time, then the contractions start, and the spine, the posture become an issue. So our intervention that need to be taken in order to try to control contractures. But the aim of it has to be clear, and we need to work with the young man about explaining why we want to recommend it, and find a balance. What do they want? Do they want to stand? Do they want to walk? Or they can't be bothered at all? And the intervention can be different. I can suggest the CAFOs, if they really, for them, it is important to be still able to stand and to do a couple of steps. I might suggest the standing frame if they said, no, I'm so terrified of standing and walking that I'm fine as I am. And the standing frame is just a stretching exercise. So also the type of intervention depends on what they are aiming for. The transition is also, I put the heart surveillance because we always, well, the previous care recommendation recommend a cardiac assessment once every 2 years until the age of 10, and once a year after the age of 10, and more frequent when they start to develop a cardiomyopathy. The reason of that is that the majority tend to develop the cardiomyopathy after the age of 10, and realistically, in the majority of the cases, is after the age of 15, 16, which obviously fall exactly in the transition time. And when they change the neuromuscular clinic, they also change the cardiology clinic. But it's something that need to be carefully monitored. Is there the time when they are higher risk to start showing some heart involvement? And because we have treatment, and if this treatment is started promptly, they can really improve the heart function, is something that we need to be careful about. Same is for the respiratory care. The updated standard of care are quite strict on the monitoring of the respiratory function. I think the transition, at the moment, with the advances in corticosteroid and treatment, I think that the respiratory involvement is delayed, and quite often is after the age of 18. But we definitely need monitoring because it's when they might start to have some side effects. As I mentioned before, is the posture. That is when they start using the wheelchair, is so easy to lose control of their posture. And the reason of that is that until they have a very good trunk mobility, it is absolutely fine to have, for example, a wheelchair with no back support. Because if you put any support, they become unable to move and to pick up things. But as soon as they lose strength, it's very easy for them. And I see so many times that is one of the arm support is slightly slower of the other one, and they start putting in this position, or in this position, or in this position, and then become a chronic posture. So it's something that we need to monitor. We recommend a spinal X-ray for the vertebral fracture now is every 1 to 2 years, but for the posture, everyone should have a spinal X-ray at the time when they start using a wheelchair as a baseline, and we know that that time the spine was straight. And then we monitor clinically every 6 months or every 12 months, and then on X-ray, depending on the needs. But as I mentioned, weight can become particularly tricky at this age. And I wanted to mention Metformin because I think that I mentioned before in the steroid talk about Metformin, because there is a lot of discussion about regarding the benefit of Metformin on muscle strength. So I think that for that perspective, there isn't really, we need to do more research on that, I have to say, because it's something that is the new testosterone. So a few years ago, nobody prescribed testosterone for Duchenne to induce puberty. And over the last probably 5-6 years, we start thinking, why not? And metformin might become the same or might not be, but it's something that needs a little bit of thinking. I'm not a big fan of metformin to improve muscle strength and function for the reason that there are no evidences. At the same time, we prescribe metformin in adult or young adult with insulin resistance, and we prescribe metformin in young adult with insulin resistance associated with obesity or overweight, and especially if there is some evidence of fat infiltration. So it's something that, although I would not recommend to everyone, I think that in some cases would be worth discuss with an endocrinologist to see the benefit and investigate whether there is any sign of diabetes, and if there is, why not using metformin? One of my concerns regarding the metformin, if there are no clinical indication, is that we don't really know. First of all, is what I mentioned at the beginning. When they become older, they tend to tire in eating and not be bothered or take too long. And therefore, actually, we need to check the weight in the opposite direction, that they do not lose weight and they don't lose appetite as a sign of breathing problem. If you give metformin, they lose appetite because it's the effect of metformin. They lose weight because it's the effect of metformin. But you need to be able to monitor it carefully and not to miss, because if they start losing too much weight, it means that they start using their muscle as energy source. And that is something that we do not want. Put them at high risk. Older men with Duchenne are at risk of malnutrition. And this has an impact on the immune system and has important consequences. The other thing that we don't know about metformin is that how long the effect of metformin on weight lasts. So if I start it and I control weight, does the effect last forever until I take metformin, or our body gets used to it? From other conditions, we know that actually there are two problems. That one of the side effects of metformin are gastrointestinal symptoms like sickness or nausea. And these side effects can appear when you start or a few years after. And therefore, you need to be careful that you want to start metformin at the right time, and not that you start it when you don't really need it, and when you need it, you can't use it anymore because you already play your card, if it makes sense. But are all questions that I have with no evidences, I have to say, but are my doubts. But I think that it is worth a referral. I think that this has been discussed today, but it's about the puberty and the growth, and I think that in transition, definitely something. The updated standard of care asks to check for puberty from the age, I think, of 8, which I think does not make any sense. We don't want to induce puberty at the age of 8, but definitely if they have not been seen before during the transition period, so I would say actually by the age of 14, all of them should be evaluated for puberty and treated if there is no signs of natural puberty. For the fracture, I think two important points that I want to make. One is the vertebral fractures, because we know that they, as I mentioned today, can be asymptomatic. And we see a lot of cases when you do an X-ray and you see multiple vertebral fracture and you do not have any history of back pain. But multiple vertebral when you have one vertebral fracture, the spine might actually collapse, and because there are treatments to control it, we want to do it. The point is that multiple fracture can be associated with chronic pain, even if it's not acute, and might be associated with the deformity of the spine. And the second thing that I want to mention is that even when the young man is not walking anymore, there are still risks of fracture and the fall. There are a lot of episodes reported of falls from the wheelchair, which are the worst one, because they quite often is the wheelchair on the top of them. And here I want to mention, because it might be a topic or anyone have question, is there is a higher risk of fat embolisms, which is a clot of fat that go into the heart following a fracture. In healthy people, we see fat embolism after massive fracture or massive traumas. In Duchenne, there have been reported a few cases after mild fractures. And is both in pediatric and adult, and both on steroid and not on steroid. So we don't know why the risk is so higher. I always think that everybody says, oh, shall we talk more about it? And I think there isn't much that we can do. I think that the point is that if they have a fall and you have the suspect of a fracture, obviously take them to the hospital. But I think if you have a suspect of the fracture, you would take them to the hospital. And the second thing is that keep an eye on if they have a fall, if they feel unwell, if they start breathing, the breathing is difficult or they are a little bit sleepy, raise your concern and go to the hospital once more instead of be at home and worried. But this would be my general advice, because otherwise there isn't so much that we can do to prevent them. Therefore, we need to do what we can. I think that I wanted to mention, although it's not really for this, is about the emergency care, because if we look at what is important in emergency care is steroid, heart function, and breathing. And this is particularly relevant for the adult population, probably more than the pediatric. So when, for any reason, you need to go to an emergency, please have some information with you, because this will make a huge impact for the clinician who see. You have to consider that E&E, probably, a clinician has never seen an adult with Duchenne, or if they've seen one. And it's natural. So tell them that if your son is on corticosteroid, for how long, what is the dose, when did he take the last dose? Does he have a heart problem? Is he on heart medication? The breathing function, if you have the latest letter with the breathing, I always think, the clinician will hate me for that, but I always think that each letter should have an introduction with diagnosis, medicine, and respiratory function. And if you take that in clinic, they will know that they are on steroid, they have Duchenne, they are on steroid, they are on heart medication, and their FVC was 1.02 liter. So they will have all information in that little paragraph. So maybe ask your clinician to put it in the letter, so it's easier. There are no clinicians here. But a general thing is, keep in mind, is push to contact a neuromuscular specialist if they are admitted to hospital. If you are under the care of the respiratory team, ask to get in touch with them. If you are under the care of a cardiologist for a cardiomyopathy, not if you are on prophylaxis, but if you have a cardiomyopathy, ask to get in touch with them. And always involve an endocrinologist for the management of steroid in case of admission to hospital. That would be my 4 message. Other aspect, and I think that this is something that we really need to work on this, because there are points that quality of life, we know that is not made, and you know better than me, is not made just of function. Quality of life is everything else. And I'm absolutely sure that if we can improve everything else, we will impact quality of life more than some of the current clinical trial. So the point is giving a life to them. And this is a little bit of a problem, and there is one of the topics is about education and employment, because when they stop going to school, find activity to do and think about their daily life. How can we make their daily life easier? And this is where probably I'm not the right person here. We should have a social care advisor here to say, how do you fight? And I know that the majority are fights. But it is important to think about how can we improve the young man quality of life, but also yours. How can you protect a little bit of your time? We need to consider that they become more dependent and do not, in a way, I know that it's very easy for me to stand here and say that, but do not feel guilty to ask for help. And sometimes they talk about have care in place, have respite in place, but this is good. For our experience, is good for the family and for the young man on board to have some rest from each other. And that is absolutely a natural thing. The problem in Duchenne is that you need to work on this and doesn't happen naturally. One big problem is education and employment, because my concern is that quite often when they stop going to school, they tend to stay at home. and it's very difficult to find employment opportunity. And then it's something that the standard of care, again, our ambition to say, plan for future vocation and consider opportunity. And the problem is, it's very difficult because find a job then for them that they can do is not so easy in the daily life. But it's true that there is a lot of work also within Action Duchenne and other patient organizations about preparing them thinking about opportunity and are trying to do something. We need to be occupied, and I always said, we are social animals, and it's important to think in advance about that. Relationship is the same thing. We are social. We need interaction with others and not just with the family. But I think that the problem here is that these are recommendations, and then think, what do you do in practice? And probably for that perspective, I'm really sorry that I'm here to present the transition, but should be parents to share experiences, because you know this better than me, and here is just a suggestion of few lists that are not really practical. But for the housing, probably I have a few words, because this is something that takes ages and need to be thought in advance. If we wait until the young man or the boy is not able to walk upstairs anymore, you will have a lot of frustration and a lot of back pain to carry them upstairs, and for them to be frustrated that they always depend on something from someone to go upstairs. So thinking about the home adaptation well in advance, involve your clinician. Some of the clinic has a social care advisor, or they can refer you to an occupational therapist, social worker in order to put in place. Ask support from the neuromuscular team to say, I need a letter of support now, because it takes a long time. There is also discussion about which kind of adaptation, and whether, for example, one of the things is that a stair lift or adaptation, moving to a bungalow, or an adaptation to allow a bedroom downstairs. Depend really locally what they can provide. I think that sometimes it's better to have the vision in the long term and not for temporary adaptation, but it's not always possible. One of the problems is how they move around. And again, it's not a straightforward answer, but it's something that needs to be taken into account. And I always have this slide when I talk about transition, because probably that is something that I heard from Josh Hendrickson, that is the psychologist that I mentioned before, is that the problem in Duchenne is that the time when is adolescence and transition period is when is for everyone, with or without Duchenne, transition is difficult. Transition and adolescence is a difficult time. Psychologically, because it's when you want to know who you will be, where do you want to go, what are you good at, and it's the time when you feel I'm not good at anything, I don't know what I want in the majority of the cases. And this happens to any child, any young man, and obviously also in one with Duchenne. But at the same time is when they usually lose the ability to walk. Some of them are told that they need a ventilation at night. The difference between them and their friends become extreme for the first time, and at the same time they have to face that they will not be able to do whatever they want. And they might not want to become a football player, but at that time when you're told that you can't, you definitely want to be a football player. And therefore it's easy to think about everything that can be done, but that is a very tricky, a very delicate time. And sometimes you think when we move and we improve the care, we have moved all this changing later, but exactly the time of the late adolescence, which make psychological input an essential component at that time. And there's another thing that is lacking in the UK is the psychological support. And I think that there is a lot of work that needs to be done in order to help them during the transition to be better men later. If we let them go, it's more tricky than to resolve concerns. And with this, I finished.